Good day, ladies and gentlemen, dear colleagues. My name is Frank Verstraete and I'm delighted to be part of the Korean Veterinary Dental Forum this year. My presentation is about surgery for oral tumors in dogs and cats. And the objectives of this presentation is to apply the principles of surgical oncology to oral tumors and to illustrate the techniques of mandibulectomy and maxillectomy. Before we get to that, I would like to emphasize that a systematic approach to oral tumor diagnosis is essential in order to secure a favorable outcome. And a systematic approach is based on clinical staging, which gives you the extent of the disease, and a biopsy, which gives you the nature of the disease. So clinical staging includes looking at the tumor characteristics, looking for lymph node metastasis and for distant metastasis. The biopsy will give you the nature of the disease. You know, what type of tumor you are dealing with and what its expected biological behavior may be. Once we know that, we have to make some decisions on how we would like to treat it. But for all intents and purposes, the two main modalities are surgery and radiation treatment. And I'll confine my lecture to the first one, namely surgery, because that is for most of us still by far the most important modality. Now, before we grab our scalpel and embark on the surgical procedure, we need to sit back and, based on the biological behavior, based on the extent of the tumor, we need to decide what we would like to achieve by performing surgery. And the best possible outcome is surgery for cure. Surgery for cure means that based upon the extent of the tumor, the nature of the tumor, with the appropriate margin, you will likely cure the animal of its disease. And here we see a nice example. This is a squamous cell carcinoma involving the rostral mandible. We know that squamous cell carcinoma rarely metastasizes in the dog. We also know that if we can obtain a margin of 10 millimeters of normal tissue, in all likelihood, this animal will be cured of its problem. So by, in this particular case, performing a bilateral rostral mandibulectomy at the level of the second premolar tooth, we are likely to cure the animal of its disease. A second option is surgery for debulking, which means that you remove the bulk of the tumor, the prominent part of the tumor, but that is never the sole therapeutic modality. So surgery for debulking always has to be followed up with something else, for example, radiation treatment. Now, this particular tumor is a plasma cell tumor, also known as a plasmacytoma in a cat. We know that plasma cell tumors are radiocurative and radiosensitive and radiocurative. So if we excise the bulk of the tumor, if we excise it flush with the surrounding normal gingiva, and then send the animal for radiation treatment, in all likelihood that will be successful. Surgery for debulking is also known as cytoreduction surgery. The next option, or the next surgical treatment objective, is surgery for palliation. So surgery for palliation means that the objective of the surgical treatment is not to cure the animal. It's also not debulking, because it's typically not followed up with anything else. The surgery is only done to make the animal more comfortable for its remaining weeks or months. And here we see an example of that. This is a fibrosarcoma in the oropharynx, a very difficult area to obtain clean margins, but the animal kept on chewing on its tumor. So to prevent that from happening, we used the CO2 laser and removed the prominent part of the tumor to prevent that from happening. So the objective of this procedure is not to cure the animal, and one has to be very clear about that to the client. You know, this won't work. This animal will die of its tumor. The tumor will keep on growing. But by removing this prominent part of the tumor, at least the animal won't be chewing on this neoplasm. And here we see the end result of the procedure. So as long as we are clear to the client that this is not curative, this is just palliation, this is an acceptable method of treatment in very, very selected cases. And then the fourth possible surgical objective is surgery for local cure. So in this particular example, this animal had a melanoma, an extensive melanoma of the right mandible. By removing the mandible, there is a good chance that, you know, the tumor won't recur at that site, but the animal will probably die of distant metastasis. That is what is known as surgery for local cure. So again, if one is clear about that to the client, that may be an objective that is acceptable to the client. So now we know why we want to perform surgery, and then that leads us to deciding what the surgical margins should be. So the surgical margins mean the area of normal tissue that should be included in the excision of the tumor. And that is determined by the biopsy result and the expected biological behavior of the tumor type. So we know that some tumor types infiltrate more deeply than others. And then that is also influenced by certain anatomical considerations. For example, the presence and location of teeth, facial planes, the presence of the orbit, and so forth. So here we can see that, you know, with a sterile pen, the planned surgical margin has been drawn on the animal, and then that is modified to suit the specific anatomical location. So you don't want to end halfway a tooth, you always want to include complete teeth in your excision. So that's why instead of stopping the incision here, we go a little further and remove the second premolar as part of our surgical margin. So based upon surgical margins, we can distinguish between 4 types of surgical excision. So a tumor is located within its pseudocapsule. The pseudocapsule consists of a reactive zone of compressed fibrous tissue. So ideally, if we remove the tumor from inside this capsule, that is known as an intracapsular incision. If we remove the tumor just outside the reactive zone, just outside that pseudocapsule, that is known as a marginal excision. And then if we apply our full surgical margin as indicated by the tumor type, so that the incision is most definitely in normal tissue, that is known as a wide excision. The 4th type of excision is not really applicable to maxillofacial and mandibular tumors. The 4th type of excision is a radical resection, and that basically involves the amputation of a leg or the amputation of the tail. So even removing an entire mandible is considered by most surgical oncologists to be a wide excision and not a radical resection. It's a matter of semantics, but for all intents and purposes, that is the terminology that I will use. So let's look at a few examples. This is an example of an intracapsular excision. An intracapsular excision is where you remove the tumor from its pseudocapsule, which is rarely indicated, and it's only indicated in the most benign of tumors. So here we see a Airedale Terrier, a 1-year-old Airedale Terrier with an odontoma of its maxilla. So an odontoma is a very, very benign tumor consisting of very well differentiated tooth-like particles. So in this particular case, you can just remove those tooth-like particles, leaving the pseudocapsule behind. So here we see the corresponding CT scan. So basically the entire maxilla on this side of the dog was occupied by tooth-like particles. So in this particular case, we created a window to the maxilla and just scooped out, removed all tooth-like particles, leaving that pseudocapsule behind. And in this particular case, this was curative, and it was curative because a odontoma is such a well differentiated tumor type that doesn't metastasize. The next example, or the next type of surgical margin, is a marginal excision. So that is where you remove the tumor together with its pseudocapsule. So you remove the tumor with a very narrow margin of normal tissue. And again, I'm showing an odontoma as an example. So this odontoma occupied the caudal mandible. So using precision osteotomy equipment, we carved out the tumor from the underlying mandible. That is known as a marginal incision. So, as I've mentioned, you need precision osteotomy equipment to do that, and I'll come back to that a little later, how we do that. So in this particular case, we carved out the tumor from the mandible, leaving behind the mandibular canal and the ventral margin of the mandible, thereby preserving the continuity of the mandible. The most commonly used method of excision is a wide excision. So a wide excision is where you take an ample amount of normal tissue in your excised area. So again, the same example that I've already shown. This is a squamous cell carcinoma. So based upon our imaging, we add 10 millimeter in all dimensions, and then we look at the presence of teeth in that line. We go a little further so that we have intact alveoli removed. So in this particular case, we would probably amputate the mandible at the level of the distal aspect of the second premolar tooth. And then we would also, remove the skin that fell within the surgical margin determined by the extent of the tumor. So I've mentioned 10 millimeter. Where does that come from? This comes from the human literature and our collective clinical experience. So there is actually no research that has looked at whether you get more recurrence with 2 millimeter, 4 millimeter, 6 millimeter, 8 millimeter, 10 millimeter, but most of my colleagues would agree that a 10 millimeter margin is adequate for a canine acanthomatous ameloblastoma and a squamous cell carcinoma. Note that these are guidelines, and the guidelines are applicable to animals of all sizes. So whether you have a very small dog or a large dog, the 10 millimeter margin still stands. For malignant melanomas, we recommend a surgical margin of 15 millimeter. And then for a fibrosarcoma and an osteosarcoma, we recommend a surgical margin of 20 millimeter. Again, these are guidelines. I do not have the literature to back up why we are recommending it, except that this is what is also done in the human literature, and it is also what coincides with our collective clinical experience. So I've mentioned intact alveoli, and the reason for that is very specific. So here we see a small canine acanthomatous ameloblastoma between the two first incisor teeth. We can see that there is bony infiltration up to the level of approximately halfway the canine tooth. But looking histologically, looking under the microscope, you can see that these ameloblastoma cells, they infiltrate the periodontal ligament because that is the path of least resistance. So one would never amputate a mandible through an alveolus and then remove the root tip. We always like to amputate in between teeth so that we have an intact alveolus. So for a bilateral rostral mandibulectomy, we amputate the mandible, we perform our osteotomy just caudal to the second premolar tooth, because by doing so we are sure that the entire alveolus of the canine tooth has been removed. Now let's look at some of the more common mandibulectomy techniques that can be performed. So various parts of the mandible can be removed, starting from the incisive part of the mandible or unilateral rostral mandibulectomy. So those are relatively small mandibulectomies, going all the way to 1 1/3, 1 1/2 mandibulectomy. So we can remove a lot of the mandibles and still have a very functional animal. You can find all the technical details in the oral and maxillofacial surgery textbook. So a few words about positioning. Positioning for a mandibulectomy is largely a matter of personal preference. So I like to do my mandibulectomies with the animal in sternal recumbency, and the way we position them is as follows. We put them in sternal recumbency and then we secure the maxilla between two IV poles. So the maxilla is suspended, the mouth is open, the endotracheal tube is fixed to the upper jaw, and then we have the entire jaw that we can work on. This is my personal preference. Some people like to do them in dorsal recumbency, some people like to perform their mandibulectomies with the animal in lateral recumbency. So the most limited type of mandibulectomy, but not the easiest type of mandibulectomy, is the excision of the incisive part. So the incision of the incisive part removes the 6 incisors, leaving the canine teeth in place and then covering them up with soft tissues. So the reason why this is not easy is that it's rather difficult to remove the 6 incisors with intact alveoli and without damaging the canine teeth. So this is not quick and easy, and one needs precision osteotomy equipment in order to do that. So here we can see an example. This dog had a very small plasma cell tumor. This is the dog in question. This is its littermate. And the advantage of this technique is that you can hardly see that this procedure has been done because it is so limited in extent. The most common, or one of the most commonly used mandibulectomy techniques is the bilateral rostral mandibulectomy. So here we see a squamous cell carcinoma. This is the clinical picture, this is the corresponding radiograph, and it also illustrates how very different squamous cell carcinomas can present. So we've already seen an example of a typical exophytic tumor, or a squamous cell carcinoma presenting as an exophytic tumor. Here we see an example of a squamous cell carcinoma that presented more like a ulcerative lesion. So here we see on the radiograph that the tumor extends approximately halfway the canine teeth. So adding 10 millimeters to that gets you about here, but we would never do a mandibulectomy there. We would typically go just caudal to the second premolar teeth in order to get the entire alveolus of the canine tooth or canine teeth out. So here this slide illustrates the same thing. So if we have a tumor involving the canine teeth, we don't try to preserve the root tip, or we don't transect the root tip and then remove the root tip. Subsequent to that, we make our osteotomy on the caudal line angle of the second premolar tooth. There are two pieces of equipment that we use for this purpose. Before I get to that, what we don't use is an oscillating saw, because that is too imprecise. So we either use a oral surgery handpiece, which can be either a contra angle or a straight handpiece. So this is a piece of equipment that is designed for oral tumor or for oral surgery. What makes it so special is that there is no air coming out of the handpiece. It is electrically driven, and it's also a closed system that irrigates the area with sterile Ringer's lactate solution. This piece of equipment has a second modality, and the second modality is what we use most commonly these days, and that's a piezosurgery handpiece. So a piezosurgery handpiece cuts bone without cutting soft tissues within limits. So if you encounter a blood vessel, it may be saved by using a piezo surgery unit. So the purpose of the osteotomy is to transect as much of the mandible as possible, but without damaging the neurovascular bundle. So we cut through about 90–95% of the bone, and then we crack the remaining bony trabeculae, distrap the two fragments, and then we ligate the neurovascular bundle without cutting it first. And that greatly cuts down on the amount of blood loss that occurs. So here we can see that being done. So the mandibles have been cut, they have been distracted from one another, but the blood vessel is still intact, and then we can ligate the inferior alveolar neurovascular bundle prior to transection. What do we do with the soft tissues of the chin? Well, that is often determined by the extent of the tumor type. So if the tumor is located in the midline, we will probably excise a triangular piece of skin as part of our 10 millimeter surgical margin. If the tumor is located more towards the side, we can make an eccentric excision, in other words, an asymmetrical excision, removing more skin from the one side than from the other. And here we see the two corresponding suture lines. Okay. So here we see how we try to avoid the sublingual caruncles, if that is possible, as determined by our surgical margin. So if the surgical margin involves the sublingual caruncles, one can transpose the caruncles or just ligate them. Another method of removing redundant skin is to remove two triangles of skin on either side of the lower jaw, and the advantage of that is that the lip margin remains preserved. So this is all determined by the individual case and by the extent of the tumor. The cosmetic and functional result of a bilateral rostral mandibulectomy is very good. So we don't attempt, or most people don't attempt to reconstruct the bilateral rostral mandibulectomy defects. If you don't reconstruct a bilateral rostral mandibulectomy, then you just cover the two stumps of mandible with the soft tissues. Dr. Arzi will talk about how we reconstruct a bilateral rostral mandibulectomy these days. And even though such a large piece of mandible has been removed, the cosmetic result is really good because the upper lips sort of mask the defect. The functional result is not ideal. So here you can see a dog that underwent a bilateral rostral mandibulectomy, and as you can see, the tongue is hanging out, and you can also see that the animal is wearing a bib. The animal is wearing a bib because the animal drools continuously. So if there is no lip margin, then you will get a continuing drooling of saliva. Also, what you will see is that the functional result initially is not very good in terms of prehension of food. So these animals, for the first 2-3 weeks when they eat very messy. There is food all over the floor. So this particular client was very innovative in addressing this. So she fed the dog in one of these party bowls. So she put the food in the central container, and then once the dog was finished eating, most of that food was found in the peripheral containers. And then she scooped everything out back into the central container, and the dog could start eating all over again. We can also perform a total unilateral mandibulectomy, something that many people refer to incorrectly as a hemimandibulectomy. The term hemimandibulectomy really is a misnomer that should be avoided. The dog has two mandibles that are joined at the symphysis. So removing one entire mandible is not a hemimandibulectomy, it's a total unilateral mandibulectomy. So that is the terminology that we prefer. So here we see an example of a fibrosarcoma that was excised with narrow margins. In this particular case, this would be a surgery for palliation or a surgery for debulking, but not surgery for cure. If you want to remove a fibrosarcoma, you would have to add a margin of 20 millimeter, which would compromise the tongue. So in this particular case, we opted for palliation. Again, the functional result of a total unilateral mandibulectomy is surprisingly good. Dogs can cope just fine with a single mandible. What you will see is that the tongue will hang out to the affected side, which typically does not cause any problem. A few technical aspects of tips on how to do a total unilateral mandibulectomy. Again, I prefer to do these in sternal recumbency, and I prefer to do this procedure completely intraorally, so we don't excise skin, which has the theoretical advantage of not involving previously uninvolved tissue planes. So in a normal mandibulectomy, or if you perform a mandibulectomy through the lateral approach, you will involve skin, and by doing that you can potentially contaminate the skin incision. By doing an intraoral approach, there is no skin contamination. So the first step is to make our mucosal incisions on either side of the mandible and the tumor, and then we dissect from rostral to caudal, cutting the muscular insertions, and then we try to transect the symphysis early in the procedure, because if you do that, you can hold on to the rostral mandible and move it to the left, to the right, and you can move it in a lateral direction, and then cut the attachment on the medial aspect of the mandible. Transecting the symphysis typically is done with an osteotome and mallet because the symphysis consists of fibrocartilage. So that seems to be the most efficient way of cutting it. So once the mandibular body is dissected, we ligate the inferior alveolar artery, or you can use a hemoclip on the inferior alveolar artery where it enters the mandibular foramen. And then we try to disarticulate the temporomandibular joint as soon as possible. One word of caution is that the maxillary artery is located on the medial aspect of the TM joint. So one tries to stay as close as possible to the bone and the temporomandibular joint. And then once the temporomandibular joint is dislocated, you can apply traction on the mandible and dissect the temporal and the masseter muscle of the bone and as close to the bone as possible. So by staying as close as possible to the bone, you minimize the amount of hemorrhage. And here we see an example of how functional a dog can be. This was a hunting dog, a Labrador Retriever, that was actively used for hunting waterfowl. And here we see the 6 weeks follow-up. He only has one mandible, but that doesn't stop him from carrying the pheasant like he has always done. So the functional result can be really good even without a complete mandible. A variation on the technique that was recently described is the total unilateral a subtotal mandibulectomy. Now with the subtotal mandibulectomy, the osteotomy is made at the level of the third premolar tooth, just making sure that you include the mandibular canal and the neurovascular bundle, but leaving the coronoid process and leaving the condylar process behind. Now by doing that, you avoid having to dissect the temporal and the masseter muscle of the bone, which is a tedious procedure and a rather difficult procedure. So by doing that, you really leave or you really cut down on your surgical time. This is only possible if the tumor does not extend too closely to this structure here. So if you see that the tumor extends closely to the neurovascular bundle, then it's safer to do a total unilateral mandibulectomy rather than a subtotal mandibulectomy. As I've mentioned, the tongue that protrudes, and the tongue that protrudes is known as glossoptosis. If the tongue protrudes, that rarely, if ever, gives you problem. It can give you problems in very hot and dry climates. Then you can see desiccation of the margin of the most rostral aspect of the tongue. So if that is an issue, then we can perform a commissurography. A commissurography means that you bring the angle of the mouth further forward. Okay, so you close the mouth to some extent. Now that is done by excising a strip of skin and oral mucosa, approximately up to this point here. So we excise that tissue, and then we suture the oral mucosa from the maxilla to the oral mucosa of the mandible, and the same for the skin. So instead of having your oral commissure right there, or here I should say, we bring it forward and the oral commissure is now there. Okay. So this suturing is done in 2 to 3 layers with lots of single interrupted sutures to prevent dehiscence. This is not something that we do routinely. We only perform this procedure if needed, if the glossoptosis is a clinical problem. Then we can also perform a segmental mandibulectomy. A segmental mandibulectomy means that here is the tumor. This was a canine acanthomatous ameloblastoma. We added 10 millimeters to that in either direction. and then we removed this segment of the mandible. So again, we performed the osteotomy on the mesial line angle, in this particular case of the third premolar tooth. By doing that, you are safe and sure that you are not damaging the second premolar tooth. And then, under normal circumstances, we leave, this defect remains a defect, and it's only closed by soft tissues. Again, my colleague, Dr. Arzi, will show how we reconstruct segmental mandibulectomies these days. But most people, most surgeons, would just leave the defect, the bony defect, as is. If you do not reconstruct a segmental mandibulectomy, then typically these cases are associated with a considerable malocclusion. So because there is a defect, the mandible will move to the affected side. Another way of preventing the mandibular drift and the malocclusion is to do a mandibular rim excision. A mandibular rim excision is a modified segmental mandibulectomy that can be done in certain very specific circumstances. First of all, you need a large dog with a small tumor, preferably a canine acanthomatous ameloblastoma or a squamous cell carcinoma that only requires a 10 millimeter margin. This was a squamous cell carcinoma, and then you have to make sure that you have 10 millimeters of bone between the visible tumor and the mandibular canal, because the idea is to leave the mandibular canal and the ventral margin consisting of cortical bone behind. But you can only do that if you are very sure that you have a 10 millimeter margin between the tumor and the mandibular canal. Hence the reason why that can only be done in large dogs, relatively large dogs. Again, you need precision equipment to excise precisely that piece of bone without damaging the neurovascular bundle. And here we see an example of that. We've already seen this example. This was the rim excision that was done for the odontoma. In young animals, you will see that the bone regenerates. This won't happen in old animals, but in young animals, the bone will spontaneously regenerate. Otherwise, if in the early days following the procedure, one has to be really careful, limiting exercise and play so that you don't get a fracture at that site. Also important in these cases is to check the surgical margin, because you only have 10 millimeters of tissue, so you have to be really sure that you don't have tumor cells remaining on the periphery of the excised specimen. And for that purpose, we use the Davidson marking system, which is basically a set of stains that we apply to the rostral margin, the ventral margin, the caudal margin, so that the pathologist can check whether those margins are tumor free. And then lastly, a mandibulectomy that we rarely perform is a caudal mandibulectomy, and this is also the only example that I'm showing today of a mandibulectomy in a cat. So this cat had a osteoma of the caudal mandible, where we did a caudal mandibulectomy. So the same procedures with some modifications can be done on the upper jaw. So again, there are various types of maxillectomy techniques. Again, a bilateral incisivectomy is not commonly performed. This was a very small squamous cell carcinoma. So again, with precision equipment, we excised a block of bone containing the incisor teeth. A more commonly performed maxillectomy technique is the bilateral rostral maxillectomy. And again, in this technique, the caudal osteotomy line would be at the distal line angle of the second premolar teeth in order to include the intact alveoli of the canine teeth. This is an example of a so-called high-low fibrosarcoma. The high refers to the aggressive biological behavior of this tumor, while the low refers to the relatively benign appearance under the microscope. This tumor type is common in large breed dogs, and the one that comes to mind first is the golden retriever. The most common site is the rostral maxilla. So here we see the excised piece, and here we see how we close these defects. We close them in a T shape, so we mobilize labial flaps and then suture them in this particular shape. So the cosmetic result is acceptable to most clients, but you can see that there is some drooping of the nose. So it's always good to have photographs available of previous cases so that you can show this to the client so that they know exactly what to expect. Here we see an example of a rostral lateral maxillectomy. So this was a canine acanthomatous ameloblastoma with the corresponding CT scan. So we made one osteotomy between the two halves of the upper jaw, so between the two incisive bones, and then the other incision was at the level of the second premolar tooth. And again, you know, these defects are not reconstructed, they are just closed with soft tissues, a nice tension-free buccal mucosal flap. And again, the cosmetic result is very good. Here you can see that the animal is still shaven, but once the hair has grown back, you know, you will hardly be able to see what an extensive procedure would have been done in this case. And then we have the caudal lateral maxillectomy, which is a slightly more challenging type of maxillectomy because the blood supply to this area is very good, but it's difficult to get by. So you have your here we have the maxillary artery that gives off the major palatine artery. It gives off pterygopalatine artery as well, sphenopalatine artery, and those blood vessels need to be ligated in order to prevent major blood loss. So this is a type of maxillectomy that is reserved for the more experienced surgeons. And here we see an example of that. This was a rather extensive caudal lateral maxillectomy performed for a fibrosarcoma, and you can see that there is a little bit of a concavity here, nothing major, but you know, at least it is visible that such an extensive procedure has been performed. Now, what is the outcome in dogs? So this is an older book chapter that summed up what was available in the literature at that time. And they found that the 1-year survival rate for a squamous cell carcinoma was about 70%. The 1-year survival rate for a melanoma was 35%. The 1-year survival rate for a fibrosarcoma was also 35%, but the reason for this low success rate was different. So animals with melanomas tend to die as a result of distant metastasis. Fibrosarcomas tend to be euthanized as a result of the high local recurrence rate. And osteosarcoma was very comparable to an osteosarcoma, and acanthomatous ameloblastoma had the best success rate in the order of 90%. Now these numbers have to be put into perspective. So not all squamous cell carcinomas give you the same results, and these are averages collected from a very large number of animals. But for example, a squamous cell carcinoma of the rostral mandible has a very different outcome compared to a squamous cell carcinoma of the oropharynx. So for a squamous cell carcinoma of the rostral part of the mandible, your success rate, your 1-year survival rate should be close to 100%. A squamous cell carcinoma of the oropharynx would have a survival rate that is much less than 70%. So, you cannot give these figures to the client without some further explanation that these are statistics, these are averages, but one has to apply our knowledge of the biological behavior based upon the appearance in the individual animal. The same applies to the fibrosarcoma. So, for example, here at UC Davis, our 1-year survival rate for fibrosarcomas is 70%. Now, that doesn't mean that we are better surgeons. It means that we are more selective in the cases that we do, and we are more precise in determining the extent of the tumor. So all cases get a CT scan, which is the modality of choice, and if we cannot obtain a 20 millimeter margin, we will probably recommend against surgery. So by doing that, we are influencing our success rate in a positive sense. So the fact that we have a 70% success rate probably means that we are more precise in determining the extent of the tumor, and we are more selective in only performing surgery in animals where we are reasonably sure that we can obtain a 20 millimeter surgical margin. For the canine acanthomatous ameloblastoma, which is a tumor type that infiltrates but never metastasizes, if you stage these cases properly and you perform the surgery correctly, there is no reason why this figure should not be 100%. So again, these are figures from the literature, but you have to put them in perspective. So in summary, the results definitely depend on case selection. So, and case selection also depends on location and the precise determination of the extent of the tumor. And then we know that the biological behavior of tumors differ. For example, a gingival squamous cell carcinoma versus a lingual carcinoma or a tonsillar squamous cell carcinoma. So gingival squamous cell carcinomas are much less likely to metastasize than lingual squamous cell carcinomas, and tonsillar squamous cell carcinomas have the highest metastatic rate. Another aspect are the technical factors. So it is technically easier to get clean margin with rostral lesions. An interesting study was done at the University of Minnesota looking at the client satisfaction following these procedures. And it was found that one of the major factors determining client satisfaction was the accurate prediction of outcome and complications. So if you tell a client that, this is a melanoma, we may achieve local cure, but your animal will likely die of distant metastasis, that is acceptable. If you don't inform them of the distant metastasis and it takes the client by surprise, they will be unhappy. So the accurate prediction of outcome and complication is important. Another example is the tongue that hangs out. If you tell the client the tongue will hang out, it won't be a problem, they will accept that. If you don't tell them before the procedure, they may be upset by the visual appearance. Unfortunately, the outcome in cats is much less favorable. And the reason for that is that a number of things. First of all, the squamous cell carcinoma, which is the most common tumor type in the cat, behaves much more aggressively in comparison to the dog. And then the second aspect is that, remember that we need a 10 millimeter margin. Cats are inherently smaller than most dogs, so it is technically oftentimes difficult to obtain a 10 millimeter margin. And then the last factor is that Cats simply do not tolerate mandibulectomy and maxillectomy as well as dogs. Remember the slide of the hunting dog carrying a pheasant 2 weeks after a mandibulectomy. Well, that would not happen in cats. Cats typically need nutritional support. They need a feeding tube. They don't eat well following these procedures. So lastly, a question that typically comes up in a mixed audience like this is, what should you refer and what should you do yourself? Well, it depends on what you have available. Do you have a CT? These procedures should not be done without CT diagnostic imaging. Surgical training, comfort level, my advice would be, start with, for example, a rostral mandibulectomy, maybe a segmental mandibulectomy before you get to a maxillectomy. And then also, it depends on what you have available in terms of equipment. So you really need an oral surgery unit and/or a piezosurgery unit if you want to do these precision osteotomies. And then you also need anesthesia support. These are team efforts in the sense that there will be blood loss. There can be considerable blood loss, and you need an anesthesia team that is able to handle that. So in conclusion, the management of oral tumors is based on the principles of surgical oncology. And then there are various mandibulectomy and maxillectomy techniques that are available, that are available for you to perform or that are available for referral. And by that, I would like to thank you for your attention. It has been my privilege to be part of the Korean Veterinary Dental Forum, and I hope that you will have a very productive and enjoyable meeting, and hopefully in the near future we will be able to meet in person again. Thank you very much for your attention.